We have got 20 minutes for panel discussion, and we have all heard that ATLG is on the Indian scenario for last 7 years. The use of ATLG or Grapholon, what in India it is called, is gradually increasing. Dr. Naseem has again brought out what better modalities and how to be given. We have got very august panelists, Professor Bhalla, Professor Ashwin Gupta, Professor Sanjeev Gulati, Professor Abi Ibrahim, and all of them have got a tremendous experience of over 30 years in the field of transplantation. All of us, these panelists, have published the data on Grapholon not once, more than once. So we are talking about their personal experience, what it is. But before I go there, I'll just give Indian studies, because Dr. Naseem has not given the Indian studies here. Let's see Indian experience. This is the largest data, prospective largest study in the world. That is the data of 359 patients from 11 centers in India. What it is showing only that the rejection episode with ATLG Grapholon was 6.5%, and graft survival and patient survival is almost 99%. This is a study by 11 centers. Coming next to the second study, which is again a prospective study from this city only, Dr. Ray and group, and again they find that the rejection and survival, there are 31 patients in each group, is similar to ATG. They are the comparison. The third study, which is again Dr. Bhalla and Dr. Ashwin Gupta sitting, is from Gangaram Hospital, a large data of 177 patients, and again they find that the biopsy-proven rejection episodes were 6.2%, and the graft survival and patient survival is excellent. They had used different doses of ATLG. We will come to that. The fourth study was again from Professor Khed, who is sitting there, and they found that the rejection episodes were a bit higher in patients on Grapholon, but the graft survival and patient survival after 1 year was similar. Last study from Coimbatore, they have used ATLG single dose of 4 milligram, a patient population of 127 patients, almost 65 in each group. They find that the 1 year graft survival was more in ATLG, death-censored graft survival was similar, and the bacterial infections were significantly less if Grapholon was used. So now we come to, this is another study we will not go because the time is short. This is Dr. Gulati and group of 54 patients. Again, they find that the graft survival and patient survival is 100% after 10.6 months, and the rejection rate was 13% in these patients. So I think we will come straight to questions. Professor Bhalla, I think, going with the KDIGO recommendations, what we have, what is your protocol? Do you prefer to give induction therapy to all your patients?
Thank you, Dr. Verma. As you have already mentioned, as per KDIGO guidelines, it is now recommended that every patient should get induction, although they have divided it into low risk group and high risk group. So in a low group where we have about 50% match, like father and mother is a donor or brother sister. So in that, preferably we should use IL-2 receptor antagonist, which is now not available. So our policy is to use Grapholon in these patients, whereas in high-risk population where we have cis antigen mismatch and pediatric transplants, spousal transplants, second or third transplants, we definitely go for ATG in this population.
Next question, I'll put it to Professor Ashwin Gupta. There are different doses recommended for ATLG. Some people have used 4 milligrams, some have used 6 milligrams, and Dr. Tolis showed me 9 milligrams. what is your protocol? What do you follow? You have got a large data published of 177 patients also.
Thank you, General Verma. Actually, we were probably the first center to start Grapholon in India once it was approved in Indian market. And how did we decide the dose? Because going by our experience of thymoglobulin since 2004, we were always to start with, we were giving low dose ATG. Many people differed at that time, but now it is there in the literature that 3 milligram total dose is enough. And going by that analogy, though it was said that 9 milligram per kilo, a single dose before the transplant. So we thought that we will give it around 5 milligram per kilo. And we monitored ALC levels daily. And in first 50 patients, we observed that 5 to 6 milligrams of our dose is able to keep the ALC count between 100 to 150. So this is how we reached at this dose. And after an analysis of 177 cases, we found that our average usage was 5.8 milligrams. So this is how we came to this dose. And mostly all the centers, whatever studies have been published, and you have mentioned, they are giving 6 milligrams.
I'll put to, let's say, Professor Gulati. How is the mechanism of ATG and ATLG different?
So, ATLG selectively, studies have shown it selectively targets the activated T lymphocytes, whereas ATG is more non-selective. It's like a cluster bomb. It targets all the lymphocytes. And that's why I see in follow-up data, you see that the risk of infections as well as the risk of malignancies in all these studies has been lower with ELTG than with ATG. So it's relatively more selective.
So you feel that mechanism of action is better of ATLG?
Activated T lymphocytes. If you look at the T lymphocyte subsets also, it targets a few subsets, whereas the ATG targets all the T lymphocytes.
Professor Abhi, when do you prefer, though I think this question was asked by Dr. Guleria, when do you prefer ATLG over ATG as induction agent?
Thank you, Dr. Verma. I use all three induction modalities. That is what is available in our country. That is thymoglobulin, then IL-2 receptor antagonist, and Grapholon for my patients.
Mic little closer.
I use all three modes of induction. I stratify them basically based on the immunological profile. For the younger recipients and those who are genetically mismatched and those who have preformed DSA, etc., I would prefer to use thymoglobulin. And those who are genetically better matched, no preformed DSA, and there's a history of malignancy or recent infection, I would prefer basiliximab. And those who fall in between, like not so high risk, but not too low risk either, in that category, I would prefer Grapholon.
Okay. Now I come to Professor Bhalla again. Let's see what is the rejection rate and graft survival rate with Grapholon, vis-a-vis, if you like to comment, ATG.
We have our own data from our center, and we have two published studies. One is by 177 patient study, which you showed. So in that study, the patient survival was 96%, and the death-censored graft survival was 100%. That was at 12 months, and at 18 months, it was 98% graft survival. Whereas in another study, which was published, multi-center study by Shishir, and our center was also part of that study, that showed almost same 98% and 96% patients.
What about the rejection rate?
Rejection rate, when we compared, it was from our center, 171 patients, it was something around 6%. Whereas in the published literature, which is from Dr. Vijay Ther's Medanta's publication, two publications from there. So there was a difference, 12% in Graflon group, biopsy-proven acute rejections, and around 5.6 or 6% in two studies in ATG group. So there was less biopsy-proven acute rejections in ATG group.
Now, let's come to the second point, Professor Ashwin Gupta, about, let's say, about the infections. Your experience, data with infections in ATLG, Graflon group, versus ATG group.
You see, in our group of 177 cases, we found infections in 22% cases, and the majority of them were UTIs. And here we did not have any comparison, but we did, our DM thesis was there where we compared Thymo with ATLG, and though it was 50 patients each, and because once the study DM is completed, you cannot publish it before that. There we have found that there was no difference in infection rate between Thymo as well as ATLG, and all other studies from India, at least there is no difference in infection rates between these two polyclonal antibodies available. So it is to the tune of around 10 to 13%.
Okay, almost similar, you say.
Yes.
Professor Gulati, any hematological disturbances? Because there is some data that possibly blood transfusion requirement is more in patients on Graflon. Any data on anything?
No, we have not really found any higher incidence of blood transfusion, but we have encountered thrombocytopenia and anemia. These are the two hematological side effects. But if you look at the average transfusion rates, they were not different between in the group that we published as well as compared to our own data with the ATG. Thrombocytopenia has been reported more often with, slightly more common with the ATLG than with ATG.
So you didn't find any increased requirement
Not at all.
of thrombocytopenia or any blood transfusion?
But one thing that we observed was that we hardly, with ATG, you do see transfusion reaction. Sometimes they've had to shift patients to ICU. So what was notable was with this 1:7 dilution, I don't recall even a single patient of infusion reaction with the ATLG, which is also part of that multicentric data that we published. So it's a very safe, patient-friendly infusion.
Coming a corollary to that, Professor Ibrahim, you can mention, I think, do you monitor lymphocyte count? And what is your protocol? Do you give standard dose? Are you monitor on basis of lymphocyte count? And what is the lymphocyte count in the long run? This is ATG.
Yeah, we do use the standard dose. That's about 5 to 6 milligram total dose. We initially give about 2 to 3 milligram per kg, and then over the next few days, the remaining dose is given. And then we don't use, lymphocyte count as a monitoring strategy because there are two ways of monitoring the efficacy. One is the total lymphocyte count, and the more accurate way is probably to do the CD3 count by flow cytometry. And unfortunately, the correlation between CD3 count and the total count is not so much. In fact, the CD3 picks up all T lymphocytes, and the total count picks up all lymphocytes, including B lymphocytes, etc. So it's not very specific. So at our center, actually, we don't monitor lymphocyte count, and we do use the normal dose based on their infection and rejection risk. And as Dr. Gulati mentioned, I too have seen significant number of patients who developed anemia and thrombocytopenia, but I don't think these numbers are any higher as compared to the thymoglobulin group.
Now, does the ATG, that lymphocyte count, persist on a lower level with ATG vis-a-vis ATLG? Anybody?
I don't think so.
Any panelists will like to have a...
Yes.
Thrombocytopenia and lymphopenia are seen more commonly with ATG as compared to ATLG.
So if the lymphocyte count is persistently low with ATG, logically the infection rate is going to be higher with that.
Yes.
Any comment on the cost analysis?
Yes. Cost, I think about this ATG one 25 milligram vial will cost around 17,000 rupees, and a 100 milligram ATLG vial will cost around 33,000 rupees.
So there is no
So if you
practically
see the total dose, I think they are almost equal.
almost similar. If there is a maybe sensitized patient, anybody, because we have got 45 seconds still left. If there is a sensitized patient or a high risk group, will you prefer Grapholon 9 milligram or you will go to ATG? Or both will be equal?
Because we know that the
I think
ATG is more potent that
we
way.
can take a comment
Yes.
from audience. Yeah, Professor K.
I think the dosages which are used, although many of these people have said, I think we tend to reduce the dosages significantly lower. There is no data of a randomized trial of 6 milligrams showing that it is equivalent to 9 milligrams or 15 milligrams, which was being used worldwide. There is data on thymoglobulin 3 milligram versus 6 milligram, and that has been looked at. I think the data suggests, in my opinion, we have published that also, you showed that, the acute rejection rates with 4 and 6 milligrams are much higher than thymoglobulin 3 milligrams. And I think the appropriate dose appears to be something like what Dr. Kumar said, is about 9 milligrams per kilogram body weight, rather than 6 milligrams or 4 milligrams in some of the centers which has been.
Last comment, Professor Mehra.
I just wanted to know your experience, because ATLG, as I see, selectively acts on the T cells, and they say activated T cells.
Yeah.
I don't know which type of activated T cells. Are they talking about CD8 cytotoxic T cells or the CD4 T cells?
CD4.
And I see that this drug has a half-life of 2 weeks. So I would expect, you seeing more of infections and tumors actually growing in these people.
All right, just a gentle reminder, we have run out of time.
Maybe a long-term study needs to be done.
I think the organizers will not allow us to go further. And I must thank the panelists. I think wonderful with their own experience. They have given the vision of how the ATLG is to be used. Thank you very much.
Thank you so much. I would like to thank the moderators and the panelists for giving us the stage back in time.